Good afternoon. Thank you, Salva. Thank you, everyone in the audience for coming. And I'd like to take the opportunity to thank Olea Medical for their generous support of this imaging symposium. In the next 40 minutes or so, I'm going to discuss brain perfusion, and we're going to discuss the theory and the practice of brain perfusion, and I'd really like to take us down to the basic parameters and how we derive the indices that we use in everyday clinical practice. This lecture is designed for the practicing radiologist. There is very little mathematics in this lecture, and when mathematics are necessary, I tend to use diagrams instead of mathematical equations. These are my industrial disclosures. And let's get started. So why do we use perfusion imaging? And there's really two basic tenets that we're looking at here. The first is we want to quantify cerebral circulation, and we want to reveal that state of tissue perfusion. And the reason we do this is to understand the pathophysiology of disease states, cancer, inflammation, and ischemia. There are two assumptions that we make when we bring this to the table. And the first is that the surrogate markers that we inject into the patient, iodinated, contrast, or gadolinium, that they imitate the circulation. And I think that's a fairly safe assumption to make. The second assumption is that the imaging data that we receive is converted into a meaningful physiologic correlate by the models, the algorithms, and the post-processing equipment that we use in everyday practice. And that second assumption is not as safe. So let's go back to 2005. This is a paper by Wintermark et al. It's in the American Journal of Neuroradiology. And in 2005, in this paper, Accuracy of Dynamic Perfusion CT, they conclude that dynamic perfusion CT maps are more accurate than non-enhanced CT in detecting hemispheric strokes. Despite limited spatial coverage, perfusion CT is highly reliable to assess the stroke extent. Okay? So let's go back a few months. And this is AJNR. The lead author is the same author, Max Wintermark. And this paper, a joint paper from three organizations, concludes, although perfusion imaging has been incorporated into acute stroke imaging algorithms at some institutions, its clinical utility has not been proved. And then perfusion CT is another method used to assess the ischemic core and penumbra. Similar to MR perfusion, there is no clear consensus on the optimal perfusion parameter that is most predictive of tissue viability and outcome. So the question is, what happened in 9 years? Why did we go from huge promise to almost a rebuttal of this field? And why has it been called into question? So I think you can break it down to four separate components. And the first one is that we use inappropriate models. The second, that our acquisition protocols are inconsistent. The third is that our post-processing that we've been using to date is inaccurate. And lastly, there's been misinformation and confusion in the literature and in practice about what are the best indices to use. So in order to address these, in order to understand these basic components, we need to go back to the beginning. So we're going to review the basics of brain perfusion imaging. We're going to look at the difficulties. And most importantly, we're going to look at some solutions to these problems. And I'm hoping, not to spoil the lecture, but at the end, I'm hoping that you believe that brain perfusion imaging is a robust, a reproducible, an informative, and a necessary technique for neuroimaging. So let's get started. When you do brain perfusion imaging, the measurable data that you have is either the signal on the MR or the attenuation characteristics on the CT within the voxel as a function of time. So we have two areas that we can measure. We can measure the arterial input function, that's the signal in the vessels, and we can measure the signal in the tissue concentration curve. So we need to convert this signal, or this Hounsfield attenuation, into contrast as a function of time, image contrast over time. So the way we do this is a simple equation. The contrast over time is equal to the signal at a given time divided by the baseline, just to give you a proportionate ratio, times the natural log of k. And now you say, aha, what's the natural log of k? That's a number that I don't know as a clinical practicing radiologist. K is a constant. It's a mathematical constant. And it depends on the contrast delivery, the angioarchitecture, and the acquisition parameters. For any given patient, K is unknown. So we've already started with an unknown estimated parameter for perfusion. And that's the reason why quantitative numbers are very difficult in perfusion imaging, because for any given patient, you don't know that log of K. That's why relative values are more transferable from case to case, from vendor to vendor, from institution, and from trial to trial. So these are 5 indices that we use in everyday practice, and most of you are probably familiar with them. Time to peak, cerebral blood volume, cerebral blood flow, mean transit time, and Tmax, the time to maximum residue function. So let's take a look at them. Time to peak. Time to peak is the only one that doesn't require complex mathematics. It's easily derived from the concentration curve. You just simply start your acquisition. When you have a maximum concentration, that is the time to peak. It's simple to obtain, and it's a time-sensitive parameter. Generally speaking, longer time to peak was interpreted as decreased cerebral blood flow, but that's completely inaccurate. Just because you have a delay of blood flow doesn't mean that your blood flow is decreased. It just means that it's getting there later. You can have perfectly adequate collaterals and a longer time to peak. So this early measure that was used for many years has been pretty much abandoned. So now we look at cerebral blood volume, and this is a very important indice. It's one that we use almost every day. CBV, cerebral blood volume, requires the least complicated mathematics. It's just simply the area under the curve of looking at the contrast concentration. So it's basically the integral of the curve. It's the most reproducible across software vendors. And you might say to yourself, it's a simple mathematical equation. That's easy. It should be reproducible. And the answer is nothing's easy, and of course not. So this is the concentration. This is a typical concentration curve, and we can see that as time progresses, the signal in the vessel increases, and then it decreases, and then at the end, it doesn't go back down to 0. So why is that? And that's because of reperfusion. We never get to the end of the contrast concentration curve because new blood flow is coming in and it corrupts the end of the curve. So how are you going to measure the area under the curve if you don't know where the curve ends? So what manufacturers do is they estimate the end of the curve. So now we have our first problem. We're estimating the end of the concentration curve to determine our cerebral blood volume. So you might say, well, that's okay. We'll just estimate it every time. We know an equation, and that won't be a problem. But that's not the way that real life works. Cerebral blood flow and cerebral blood volume, cerebral blood flow, and the concentration curve is different in different parts of the brain. This is the arterial input function. Here's the gray matter input function, which is slightly delayed and lower. And here's the white matter input function. It's even more delayed. So why would that be problematic? And the reason, you can see from this very high-tech diagram, is that when you measure the arterial input function, which is what we do, we measure the blood in we measure the contrast in the artery, and we say, here's the end of the curve, we're going to stop it here, the tissue is continuing to decrease. That delay is the reason we underestimate the cerebral blood volume every time. It's because of the natural delay, physiologic delays within the brain and the tissues and the arteries. So why is this important? It's because of how we think about cerebral blood volume. The common paradigm that people work with is that as cerebral blood flow decreases, autoregulation kicks in, causes vasodilatation, and that increases cerebral blood volume to maintain your cerebral blood flow so you have adequate delivery of oxygen and metabolites. And then as cerebral blood flow continues to decrease, it drops below the ability of autoregulation and vasodilatation to compensate, so cerebral blood flow starts to fall off. You can no longer compensate. Cerebral blood volume drops, and that cerebral blood volume dropping had been for many years interpreted as the marker for infarction. So the problem is that we underestimate cerebral blood volume routinely. and that gives us erroneous diagnosis of infarction. As a matter of fact, in one study, if you took the measurement out long enough, all those areas of cerebral blood volume that people were using to indicate infarction normalized. So this is our first problem. We were using an erroneous marker. I'm not the first guy to say this. There are several papers out there that looked at cerebral blood volume and they said, hey, maybe this isn't what we should be using as our marker of infarction. And here's an article by Campbell et al., and they say, in contrast to previous reports, cerebral blood flow corresponded with acute diffusion-weighted imaging, right, our gold standard of infarction, better than CBV. And then in a separate paper by Brevard, he looked at a comprehensive analysis of this. He said a double core threshold, and he was using cerebral blood flow and mean transit time, two indices together, with a delay of more than 2 seconds, Tmax of greater than 2 seconds, and cerebral blood flow of less than 40%, provided the most accurate definition of infarct core. So we've moved away from CBV. And this was so astounding that he even felt the need to say this is a departure from the previous widely accepted view that CBV is best to use to define infarct core. So that takes us to cerebral blood flow. And that makes sense, right? If you're looking at areas of infarction that have low cerebral blood flow, then why don't you just simply measure cerebral blood flow? The cerebral blood flow is determined in the following fashion, in the most simplistic way. As the concentration of the curve increases in the voxel, the slope of that curve is the representation of blood flow. Blood flow moves in quickly, you have a steep slope, that's a faster cerebral blood flow. If the contrast moves in slowly, the slope is less, and that's a slower cerebral blood flow. Ideally, you would like a rapid, well-defined, and compact bolus so that you could really get the contrast into the vessels as quickly as possible. This simple measurement is not accurate with clinical imaging, unfortunately. That curve is affected by contrast type, the injection rate, mixing of opacified and non-opacified blood, cardiac output, and even the angioarchitecture by collateral flow. This is a slide that I like to use when lecturing about CTA and techniques of CTA, and it works very well for this lecture. This is the contrast curve if you inject 8 cc's per second, and this is the contrast concentration curve if you inject 4 cc's per second. We can see that in the same patient with the same cerebral blood flow, this first curve has a much steeper slope and hence interpreted as cerebral blood flow being faster than this second curve. So we can see that we're not measuring blood flow, we're measuring injection rate. Same thing for the viscosity of the contrast. This is a low viscosity curve, and it goes in quickly, so it has a very steep slope. And this is a high contrast viscosity curve, a little bit slower, which you would interpret as decreased blood flow. The blood flow hasn't changed, you've just changed your contrast. So how do we fix this problem? And the answer to that is we just abandon it completely. There are better ways of looking at cerebral blood flow. But to do that, now we need to introduce a little mathematics. Excuse me. So the signal intensity in a voxel is not an accurate representation of cerebral blood flow. The upslope is mostly due to the accumulation of contrast in the blood vessels. We're not really measuring blood flow, we're measuring injection. So theoretically, the best way to measure blood flow would be if you could instantaneously put the contrast in a voxel and then watch it disappear. And that's exactly what our current algorithms are doing. We use deconvolution methods to solve for this. And what these deconvolution methods do is they normalize the concentration in the tissue and the arterial input function. So I don't want you to leave here without really understanding the basics. So we're going to go into convolution algorithms. So basically what they are, they're complex equations that convert concentration time curves and arterial input function into meaningful clinical parameters. And these are mathematical equations that basically work on two functions at the same time to solve them for a third function. And what it does is it takes one function, it moves it through the second over time, and then it gives you a third function. And because you can get anything on the internet, this is a graphic demonstration of convolution mathematics. Well, maybe not. There we go. So let's think of this as one concentration curve, the red one. Let's think of this as a second concentration curve, the blue one. And as we translate one into the other, you see the area under the curve. And now we're graphing that area under the curve. So first we have a pretty large area. It's continuing to increase. And then as the curve goes down, we maximize. And then as the curve goes down, the function becomes less. That's exactly what these complex convolution algorithms are doing. So we measure the arterial input function, the blood in the the signal intensity in the arteries. We measure the contrast signal in the tissue. And what we use is convolution methods to give us the residue function. The residue function is a curve that gives you the instantaneous signal of contrast, sometimes called the impulse, and the washout curve of that contrast. We use that currently to determine the cerebral blood flow, the Tmax, and the mean transit time. So let's take a look at that. This would be the arterial input function. You can see the contrast rising in the artery and then decreasing. And then over here, this would be the tissue contrast, a little bit more delayed, a little bit more splayed out. If we take the tissue concentration, the arterial input function, and we use deconvolution methods, we get the residue function. And you can see the residue function is flat, and then it spikes up in just a second. And the height of that spike is the CBF. So if you think about it, if you have a big cerebral blood flow, you would get a big instantaneous amount of contrast in the voxel, and that's big cerebral blood flow. If you have less cerebral blood flow, you would have a smaller upstart of the residue function, and that's lower cerebral blood flow. So, in that thought paradigm, it makes sense. When that happens, when that impulse happens, that's Tmax. And as it disperses, as the contrast leaves, if you take the weighted average, that's mean transit time. Tmax is not a true physiologic value. It's a theoretical construct. It reflects the bolus arrival time, and an increased Tmax is thought to represent delayed or collateral circulation. It's easier to determine, it's easier to interpret than cerebral blood flow because it's in seconds. There's no gray-white matter differences. So that's why people like Tmax. It's just one quantity, seconds. Traditionally, we interpret Tmax as correlating with the final infarct volume. Now, here's the problem. Here's two papers, two well-done papers, that said that a Tmax of 4 to 6 seconds or a Tmax of 5.5 seconds defines penumbra. So in these two different papers, they found two different values of Tmax, kind of overlapping but a little bit vague, about what defines what the ultimate infarct will be. So Tmax was used for several major stroke intervention trials for treating patients 3 to 6 hours after infarction, the diffuse 1, the diffuse 2, the epithet. And in these trials, Tmax used was greater than 2, greater than 6, greater than 2. So we have different trials using different Tmaxes. Tmax is strongly influenced by signal to noise. Depending upon how good your study is, that's going to influence what your Tmax comes back as. And the problem is that Tmax is a theoretical construct. Again, just because you have delayed flow doesn't necessarily mean that you're going to infarct. So mean transit time is the second correlate that people use. It's basically the average time that the blood stays in the tissue. And you can determine it from the concentration curve, but we're not going to do that because we know that's corrupted by the injection. We can determine the CBV and the CBF, but we know that's corrupted by injection. So we use the residue function. And here we can see it's the average of the volume under that curve as the contrast disperses. Mean transit time has been interpreted as being increasing mean transit time, longer flow through the tissue is a reduced CBF or an elevated cerebral blood volume. And a relative mean transit time, meaning the mean transit time on the abnormal side versus the mean transit time on the normal side, if it's 145%, that's considered infarcted tissue. And if it's slightly less, or depending upon the study, it defines penumbra. The advantages of mean transit time, it's sensitive, it's conspicuous. You can look at mean transit time and know the area that's involved. It's very easy to see. The disadvantages, Delayed flow through the tissue, again, doesn't necessarily mean infarction, and mean transit time is degraded by all of those same factors. So we've just gone through all the major indices that there is in stroke imaging, and for blood volume and for tumor imaging, and all of the brain perfusion indices. So how are we doing with this? So the first is a clinical study by Kudo and Sasaki, and they took real data, and they used 5 different manufacturers, and they determined infarct size with different vendor software. Same data, different vendors. And what you can see is cerebral blood flow. This is the mean transit time. We have varying sizes of infarct depending upon which vendor software you utilize. And if you look at the final infarct and say, well, what was the indice that would have decided it for me, they're different. A cerebral blood flow, relative cerebral blood flow, and relative mean transit time on one vendor did not at all translate to another vendor. We shouldn't be surprised by this because Kamalian et al. Put out an article that concluded that the absolute cerebral blood flow thresholds, and this is in a real clinical trial, absolute CBF thresholds were 4.7, 5.4, and 10, and the normalized thresholds, 84%, 72%, and 68% reductions, okay, relative from the abnormal side to the normal side, to determine the size of the infarct. 3 different vendors, same patient data, different results. What's the consequence of this? Well, Gilberto Gonzalez, in the Massachusetts General Hospital Stroke Consensus Study, said at the ASFNR in March of 2012, there's no advantage to CT perfusion in the evaluation of stroke. It's unreliable for determining infarct core. That's a pretty big statement. We just discounted CT perfusion for stroke. And here's the article. It was in the Journal of Neurointerventional Surgery. And he makes a point of saying MR is better because the contrast to noise ratio on the MR for the diffusion-weighted imaging is 8-to-1 contrast to noise, while on the CBF images for MR, it's less than 1. So it's a signal-to-noise problem. This is a CT from my institution. It's somebody with a lenticular striate infarct. It's hard to see, but there's an ROI in the infarcted basal ganglia, and there's an ROI in the normal basal ganglia, and then again in the infarcted centrum semiovalli and the normal centrum semiovalli, and using American College of Radiology criteria for standard deviation, we have a signal-to-noise ratio of the infarct compared to the normal side of 1. And on the centrum semiovalli, 0.5, meaning the imaging contrast difference between our abnormal tissue and our normal tissue is almost nothing. So, is there an influence? Does that have a consequence? Sure. This is the MR rescue trial. This is February 2013. These investigators thought to themselves, hey, we're going to use imaging, and we're going to try to see if there's a group of patients who will benefit from thrombectomy. We're going to look for patients who have a small stroke now, but a large territory at risk. And we're going to see if we can do a thrombectomy on those patients, and those who have a big territory at risk, maybe they're the ones we're going to salvage. And their conclusion? A favorable penumbral pattern on neuroimaging did not identify patients who would benefit from endovascular therapy. Okay, so the question is that true? You mean taking the clot out of someone's middle cerebral artery didn't help them? It's counterintuitive. I mean, it happens in medicine. Counterintuitive things happen all the time. But we just said that if you have a large territory at risk, removing the clot didn't do anything. In that paper, they used a Tmax for MR of greater than 4. So now we see a new Tmax that we're using. I showed you some other thresholds in the other papers. Now we have a new number that we're using. And for CT, and for the penumbral region, an MTT of greater than, 6 was used for CT. So even if there was a different modality in that study, we have a different Tmax. Here's a paper, same authors. Not the same paper, but they described their methods that they used in the MR rescue trial. The infarct core models had an overall accuracy of 71 to 80%. So we based a clinical trial on a technique that has 70% accuracy. So if you're starting with your gold standard of 70% accuracy, how well do you think you're going to be able to figure out the subtle differences in clinical outcome? We now know enough, we meaning everyone in the audience, now knows enough because you understand the basic principles of brain perfusion to kind of get around this, to figure out how can we improve on this. So there are a couple of things that we can do. The first thing we can do is we can measure arterial input function local instead of global. So people are used to global single values. When you do a cerebral perfusion study, you put your marker on one of the blood vessels going into the brain, and that is your arterial input function. The problem is there's a long delay between that artery and the tissue, and we know that delay is bad because delay cuts off the end of the curve. So a better way of doing it might be as follows. Let's get lots of arterial input functions. Let's get them all over the brain. Let's get them closer to the tissue so that our arterial input function matches more closely the tissue that we want to study. And this is using SPHERE, and we can see multiple areas of the MCA bilaterally being measured, more distally in the MCA, more distally in the MCA territories, all the way out to the distal vasculature. Now we have an arterial input function that really reflects what's going on in the entire brain. Does this make a difference? Absolutely. These are two different methods of determining the size of an infarct. The first is global, and we see this large area of left MCA infarction. The second is the local AIF, and we see this small area of infarction. And here is the diffusion. And you can see how the global AIF, which has a long delay, grossly overestimates the size of the infarct. 2, we can use better mathematical algorithms. Ultimately, it boils down to those convolution algorithms that we were discussing. The best of these algorithms are time insensitive. They are more resistant to those delays in time that cause us problems. So oscillating single value deconvolution is a better way of looking at these indices. So not all SVD methods created the same. And here we see a graph of the true value 1-to-1. And here we can see these are the more traditional single value deconvolution methods. And here is the OSVD. And we can see it's not perfect, but it's certainly closer to the true value than these older methods. This blue, the dotted line is a phantom digital data. This is digital data, phantom. And the blue line is the single value deconvolution that you receive. And we can see that these single value deconvolutions oscillate around the true values. So that when you measure the curve, it's a little bit short, that concentration curve. And that's because these single value deconvolution methods are sensitive to noise. When you image, you have noise. When you introduce noise into your imaging, you introduce uncertainty. And when you introduce uncertainty, you introduce oscillations because you're not exactly sure where the true value is. So, is there a better way of doing it? And that's where Bayesian models come in. Bayes' theorem is a maximum likelihood theorem. It's a probabilistic method, and it uses assumptions based on prior knowledge of flow as well as models of microvasculature. And the best thing about Bayesian models is that they're insensitive to that AIF, arterial input function, tissue concentration delay, and they're more accurate at low signal to noise. So, Bayesian models have a better correlation with true values than traditional single value deconvolution. Bayesian models have greater accuracy at the extremes of measurement when blood flow is low or high or blood volume is low or high. And why is that important? Because that's what we use it for. We don't measure normal people. We measure tumors that have a high cerebral blood volume, and that throws off our traditional models. Or we do it during stroke when there's very little cerebral blood flow, which throws our models off. Bayesian algorithms are more accurate at these extremes. And there's a better differentiation between normal and pathological. So here's again a digital phantom, and we can see the true value is the red. The blue we've seen the oscillating SVD, And you can see that the red, which is a Bayesian algorithm, closely fits the true data. And then in the concentration curve, you can see that the Bayesian algorithm, much sharper. It fits the true data curve a little bit better. So once you have Bayesian algorithms, now you can use different indices. So with Bayesian algorithms, you can look at arterial tissue delay. And I apologize, it should be arterial tissue delay, not arterial time delay. The time between the arrival of the arterial input function in the blood vessel and the concentration in the tissue is that arterial tissue delay. With Bayesian, you get an actual, true measurement that is not corrupted by the same factors that corrupt Tmax, signal to noise, slow mean transit time. It's a more accurate measurement of the adequacy of collateral flow. Secondly, because you have a more accurate calculation, you have a more accurate calculation of CBF, and that's the index that we want to use to estimate what the infarct volume is. So we have limited clinical data since Bayesian algorithms have not been around very long. So there's one abstract indicated that arterial tissue delay greater than 6 seconds in patients with MCA M1 occlusions has a significant correlation with the angiographic collateral flow. These are patients who had angiograms during intraarterial thrombolysis. They looked at the ATD, and a longer ATD had worse collateral circulation. In these same patients who had intravenous thrombolysis, those who had poor CBF also had a longer arterial tissue delay. Secondly, in a clinical trial, when you take two parameters, the arterial tissue delay and the size of the infarct by diffusion imaging, those two indices together, multi-parametric indices, best predicted non-recanalization for the MCA M1 territory. And when you put both of them together, they also best correlate with angiographic collateral flow. In summary, clinical application of perfusion imaging has suffered from inaccuracies and inconsistencies, but newer models and algorithms will be helpful, and they seem to correlate better with our gold standard of MR diffusion imaging. Cerebral blood flow and probably multi-parametric indices are the are the measure of infarction. Cerebral blood volume is not. And lastly, mean transit time and Tmax are commonly utilized but problematic indices of collateral flow and penumbra, but it may seem that arterial tissue delay may be a more accurate way of determining it. And hopefully, with newer models, newer algorithms, newer techniques, we can have an accurate, robust, reproducible, and necessary imaging technique with brain perfusion imaging. Thank you.